We know in government, I'm afraid we're living through extraordinary times that sort of people worried about risk, their appetite for risk in government. Who do you think handles risk better, the NHS or Whitehall?
I think it's difficult to kind of ascribe a label of how the NHS handles risks as a monolith. I think the people that feel risk and closest are probably surgeons in the NHS, and I think we do a reasonable job most of the time. I think where the NHS falls down, and it's not entirely its own fault, is at a academic and institutional level. I think a bit like Whitehall, actually, we're becoming increasingly paralysed by risk.
What do you think the role of SMEs are in NHS procurement, and how they can get more involved in some of that innovation and delivery?
NHS technological transformation project that does not give space for British grown SMEs has failed before it starts. We have never properly leveraged in this country buyer or the sole buyer status, sole purchaser status of the NHS as a national asset to grow our own businesses.
How do we get these small pilots, and then talking around healthcare being one of the biggest spends for government daily, how do you work on scaling that?
I think that's where the NHS needs to think about. It's got a clinical entrepreneurship programme, which is run for over 12 years, run by a brilliant urologist called Tony, whose surname currently eludes me. He'll kill me when he finds it. I don't remember his surname. From Essex.
Use AI to put it in after.
That's right. From Essex.
What's more stressful, Operation Theatre or the chamber in Parliament?
Well, certainly politics is more stressful than surgery. I would say so.
What would be the best piece of advice you've received within your medicine career or within politics?
The best piece of advice I've received.
Hi and welcome to the latest edition of the Digital State podcast, and I'm really looking forward to this one because we've talked about a lot of different things in the series so far, but this one we're going to be focusing on health tech and all of the ethics and technology growth that's possible through health. We've, as usual, got Asad Ansari, the Chief Executive of Mayfair IT Consultancy. Asad, I think this should be a really interesting one because it's all about first of all, about how you deal with technology alongside safety and trust in that, but also those opportunities.
I mean, public trust is a big thing when it comes to healthcare. And not only that, when you pair up technology within that, with some of the uncertainties that we've seen globally, cyber, data, AI, where are the opportunities within healthcare overall, life sciences, medtech, and of course, AI, and how we can use that. So we'll be able to drive out some of that today with our guest here.
Fantastic. And with no further ado, let me introduce the guest. There's Dr Zubir Ahmed, who was the MP for Glasgow South West. He's was the Parliamentary Under-Secretary for Health, Innovation and Safety. And surprise, surprise, this is a minister that actually knows what he's talking about. He's a former surgeon. So he's been right literally at the cutting edge of healthcare in this country. He knows health, the NHS, inside and out, and the possibilities that are there. So Dr Zubir Ahmed, Zubir, welcome.
Thank you very much. And I'm still a surgeon proudly. I could never give it up, really. It's part of my DNA. So
fantastic.
I still do a bit.
Do you have to keep that in sort of part for your regulation as well? Do a bit of rotation work for that?
Yeah. So you like everything, every profession, there's got to be continuous professional development. But for me, it's also just for continuous professional sanity that I do it. It's a wonderful thing that I am privileged enough to do, and I can't ever see a situation where I would give it up, to be honest, even in small doses.
Well, I suppose if it's there, it's ingrained in you. You studied hard enough for it as well, and worked hard enough to get there. So congratulations to you. And I understand that you used to do a bit of practice down in my old patch in the Royal Marsden in Sutton as well.
Yeah, so I spent a bit of my time doing research in London, in King's and the Royal Free, and my boss at the Royal Free at the time was trying to develop a kind of non-invasive way of blasting liver tumours. So I was down in your patch in the Marsden and Sutton working out how to use ultrasound to blast liver tumours, yeah.
Now, we talk about risk a lot, and I remember reading a book by Matthew Syed, Black Box Thinking, when he contrasts the NHS and, unfortunately mistakes happen, we know this in all these things, compared to airlines and what have you. And we know in government, I'm afraid we're living through extraordinary times that sort of people worried about risk, their appetite for risk in government. Who do you think handles risk better, the NHS or Whitehall?
I think it's difficult to kind of ascribe a label of how the NHS handles risks as a monolith. I mean, I would say this, I'm biased, but I think the people that feel risk and the closest are probably surgeons in the NHS, and I think we do a reasonable job most of the time of calculating risk, actually communicating risk to patients. I think where the NHS falls down, and it's not entirely its own fault, is at a systemic and institutional level. I think a bit like Whitehall, actually, we're becoming increasingly paralysed by risk.
Right. Okay. And are you paralysed by size? I'm not advocating changing it in any way, but I mean, when government or the NHS get to a big scale, that can be an advantage, competitive advantage. We'll talk about later. But just in terms of process for risk,
I think that's certainly true with government and Whitehall, and arguably with DH. It's a chunky department, as you know. 44% of daily government expenditure going through one department is pretty massive. So I think that does paralyse it in terms of its risk appetite and risk management. I think with the NHS, actually, the converse is true. Most people would think of the NHS as one entity, but you'll know, having been in government, that actually it's very fragmented. There's many trusts, there's many individual organisations. And that's fine. I think that's okay. But what that sometimes leads to, I think, is unconscious or subconscious kind of deviation from a norm, and then you end up with very different cultures in different parts of the NHS and how they approach risk. And sometimes it's a bit like football. You feel like you're only as good as your last result, and that is the thing that's defining how you approach the next issue or the next kind of suite of risk that you have to manage in the boardroom. So I think there is an issue there.
And how do you work through? How does the NHS work through its sort of appetite for technology? In so much that I remember back in the day when Matt Hancock was a health secretary and he launched NHS X. I think that was Matt that did that, which became NHS I think England Digital, and then it's gone through a few iterations. And because X was always put onto everything to make it more exciting and what have you, but. How has it been embedded in the very being of the NHS and the daily practice?
Individually, like as a minister or someone working in the NHS, you can point to great successes of a digital transformation that's taken place here or there to reduce, front door pressure on an A&E department or a GP surgery or, whatever. But I think what's been lacking is that the technology has been moving so quickly that if we're honest with ourselves, within the NHS and within the department and probably within the civil service, we have not had the capability, the capacity, and probably the technical expertise to make major decisions and to pick lanes where we needed to help the NHS move quickly, in its entirety. And procurement is one of those areas. I think it's all fine and well talking about devolution. I'm a big fan of devolution politically and actually structurally for the NHS, but when there's such a kind of era of disruption going on with technological transformation, the centre also does need to grip certain issues quite quickly, define its expectations to the rest of the institution, in this case the NHS. I don't think we've been good at that, and I think part of that is back to the expertise. We've not been able to, have those expertise on our side that's been quickly able to distill information, interrogate the prospectus that technology is bringing to us. That because for every problem in the NHS, there's 100 companies out there that'll tell you they've got the solution and they're going to save you X billion amount of money in doing it. But what we have to do in the NHS and the department is move through those gears quickly and get to the answer. I think that's where Digital X and NHS Digital has not come into its own, because it's been, like you say, an adjunct to processes as they are, rather than thinking about how the technology actually can transform some of those processes, some of those clinical pathways, rather than just bolt on a digital solution to an existing pathway. If we do that, we're never going to get out of this little kind of, I would say, paralysis that we're in right now, or the status quo where we just spend more and more money on the NHS and get less and less in return. If technology is going to transform the NHS, it's got to do it to the pathway and to the patient interaction with the NHS, not just digitalise what's going on right now.
Yeah, I think that's a really important thing about just digitalising things. I remember when I was tech minister, totally different situation, but I went to Japan for the G7, and Japan was one of those nations that's often talked about digitally, but actually what they did, they digitized their analog nature. So paper became PDFs rather than natively digital. And that suggests what you're saying, similar to what you're saying in the NHS. You just can't just scan everything in. You've got to do it ground up, right?
You do. And the good thing is, with AI, you've got a type of intelligence and thinking that's going on there, rather than just process automation. And with the data sets that underpin the NHS, you've got a unique source and uniquely diverse and complete source of information to train that artificial intelligence, to do it in a bespoke way for what's right for your country, for your part, your region, for your city, for your hospital, but still be able to make the big decisions as to what tech you actually procure to do it. And then, of course, that leads you automatically, especially in the era we're in right now, about who should we buy that tech off, intersections with sovereignty and national capability and critical infrastructure and all that kind of stuff, which is exactly the conversations we need to be having right now, right this minute. So we set the parameters upon which we procure this stuff on.
Well, let me try and separate them, but I'm not sure they are separable given what you just said. But first of all, when the NHS, you talked about how it's made up of lots of smaller organisations. Sometimes they work better with each other than others, but it can be flexible. If it's local, it can be very much more flexible. If it's national, though, you've got the economies of scale and the power of that size. Data being one of them.
Yeah,
I mean, the NHS has got pretty well the biggest single data set in the whole world.
In theory,
but
not in practice, unfortunately.
Okay,
yeah.
And is that because of the separation of the sort of fraction?
I think, I mean, I think it's for a number of reasons. Ultimately, it's because no one designed the technological ecosystem of the NHS from scratch. We didn't have that luxury. We did it from very much a needs-based approach. Each individual organisation did it. They then tried to bolt it together. That's why that's why probably other countries that didn't do this bit now can start from scratch and have the ability to technologically leapfrog us. Right? Look at what the Indians have done. Yeah. For instance, they're far ahead of us in terms of their technological transformation of health services.
And is it doable in the UK?
It is doable in the UK. It needs, I think, strong political direction, at time political argument, because it can get stuck in the kind of treacle of sometimes good faith, but often bad faith conversations around trust, privacy, sovereignty, which I do not think are by any means insurmountable. So I think it's totally doable, but it can't be done without strong political direction.
Yeah, absolutely. Yeah. And it's something.
And by the way, consensus.
Yeah.
Cross-party consensus.
Yeah. No, I get that because and I would hope. I mean, look, politics is free bar. We know that. We know that what's playing out at the moment. It's very free bar. But for something that David Cameron was speaking about before I was even elected, he was trying to bring things together.
Yeah.
There is a sense that most of the parties should be looking at doing that. But of course, there is a narrative gap, isn't there, with the members of the public, I think, in terms of trust of data.
Yeah, do you know what? The data that I've seen on trust is actually pretty encouraging. Natively, when you ask people, should bits of the NHS link together, work together, they either say yes or they think, we thought all that already happened. They find it quite an anathema that you go to a hospital, say for instance St Mary's down the road, and they've got no idea what happened to you at the Royal Free last week. They don't understand why that should be the case. So from that sense, the public is expecting this to happen, wants this to happen, understands it needs to happen. I think it runs into the buffers is when you get into the weeds of a conversation about GP data being accessible by a hospital or a pharmacy, is that rightly there will be questions about what the limitations of that access should be. But quickly it becomes a conversation about, say for instance in the GP world, only GPs are trusted enough to handle this data. They couldn't possibly give it up. But actually, if some GPs are honest with themselves, particularly the BMA GPs committee, what they're really saying is we want to use this as leverage as part of a contractual negotiation with the government. And so that's when I think some of the bad faith comes into these arguments. And then as well as I do, in the kind of attention economy we're in right now, if it's a 15-second clip where there's a Commons debate about your mum's whole data being shared with a pharmacy without her permission is conceivably possible or could happen in this new environment that we're living in, it suddenly, I think, scares a lot of people. What they don't understand is actually the way data is stored and curated at the moment is probably less secure than it would be if we actually designed it properly. The status quo is not benign in that sense, and it's not secure, right? Because we are open to attack from international actors or things going wrong domestically because we haven't actually invested that much into our technological architecture or spine, or digital spine of the NHS. So actually transforming it makes it more secure. And I would say, I would treat NHS data like proper national kind of critical infrastructure. And I certainly, when I was a minister, spoke about its security as being military grade security.
How much of the narrative then, given what you just said, of trust is about the companies that you might bring in? I mean, obviously there's a I have to pick them out because it's newsworthy, right? But not picking on them. Is Palantir. So because it becomes then a values thing, it very quickly becomes a political thing rather than a company that it may be best for the job. But there's also an international element, because if you're going to talk about critical national infrastructure, ideally you want something UK-led. You want the data to be kept here.
I think ideally you do, yeah.
Yeah. How do you square that though?
Well, listen, let me just kind of address the Palantir thing first, because it obviously did arise during my time as a minister. I had to respond to a debate on it specifically in Westminster Hall. All I would say is, like, everyone is entitled to make values-based arguments as to who should be able to come and play in our pitch as a United Kingdom, whether it's in healthcare or defence or HMRC or whatever it is, wherever there's big infrastructure projects, digital infrastructure projects going on right now. And I've said this again on the floor of Westminster Hall, I have no love or warmth for the political views of the owners of Palantir. In fact, quite the opposite. But if you are a serious nation who believes in a rule-based order and a rule-based procurement system, you do have to allow everyone to compete on an even playing field. You, of course, set the rules as to what that might be. I think it is very reasonable to ask searching questions, given today's geopolitical climate, even compared to 3 years ago, about what those prerequisites should be to come and play here, especially when it comes to NHS data. I think it's quite reasonable to say, well, we need an end-to-end assurance of sovereignty, both for raw data, analytical insights, outputs, whatever other layers you put on top, to bring different reams of data together. That I think is quite reasonable to make an argument to say all of that needs to be sovereign in some sense and never should leave the country, including the insights. That's a perfectly reasonable position, and that could be something that could be locked into a future procurement process. With Palantir, there's obviously going to be a break clause. There's going to be an assessment based on value. That's the right thing to do. As far as everything that I saw back then, it was very clear to me that at that point, on the needs-based assessments that were done, there wasn't a UK equivalent company ready to go. Yeah. But 3 years is a long time not only in politics, but a very long time in technological transformation and AI. And there may be companies out there now that are ready to go. And in the new world that we're in right now, we should certainly be considering future procurement through that lens of national resilience and sovereignty. And I don't think we should apologise for that, actually, personally. But again, at the same time, it's completely unreasonable to say we can somehow function without technology from elsewhere. If I think about my daily working pattern in a hospital when I walk in, and this is in Scotland, by the way, where there's no Palantir, which they sometimes use as a browbeating stick. Some of the politicians up there, when I say to them, look, why haven't you got an NHS app? Why aren't you not more integrated? Look, even up there, I log in on a Microsoft computer. I then open up a program to look at X-rays, that's American. I open up another program to order blood tests, that is North American. I open up a fourth program to see the results, which is North American. So this idea that this is a Palantir-only problem, and only if we could get rid of Palantir, we could become so sovereign and wholesome in our NHS is something that's never happened or existed, and is not likely to exist. We're always going to have to rely on partnerships to deliver healthcare, whether it's technology, whether it's your scanners that are made by Siemens, whether it's your surgical instruments that are made by Stryker, which is another American company. We have to, that's the world we live in. It is about partnership. But in terms of mitigating that word again, risk, and making sure we're diversifying our supply chains and the rest of it, I think it is very reasonable when we're thinking about big infrastructure, digital infrastructure projects, to think about what we ascribe value to, not just the cost line, the bottom line on a balance sheet, but also what societal value is government procurement bringing. I think that is something we need to get deeply into.
So given the size of the NHS, as we're talking about, although, as you say, it's fractious in some areas, what do you think the role of SMEs are in NHS procurement, and how they can get more involved in some of that innovation and delivery?
I think any NHS technological transformation project that does not give space for British-grown SMEs has failed before it starts. Like we have never properly leveraged in this country the unique buyer or the sole buyer status, sole purchaser status of the NHS as a national asset to grow our own businesses. And we need to completely change that mindset. And that's part of that societal value calculation for me when you're doing your procurement bids. What are we doing for businesses here? What are we doing for SMEs in particular here? We are at the moment one of the most fertile grounds in the world, as you probably know, for AI-based businesses to be developing here. The venture capital money itself tells you its story, but also biotechnology businesses. There's, and they're usually, a lot of them are being started by second, third generation immigrant families, like myself, who are, maybe have a different risk appetite at times, given how we've been brought up, and they're going full steam ahead. And what they're doing at a certain point is they're coming up against the buffers of investment and capital, and we're losing them. And I'm not talking about hundreds of millions of pounds, by the way. I'm talking about even in the £2 to £20 million bracket. They are having to jump ship, and it's often to our friends across the pond. We need to sort that out quickly. Yeah. And I think at that level, at the £2 to £20 million level, I think the NHS really needs to ask itself some searching questions. What is it doing to engender a sense of entrepreneurship and growth for some of these companies? Because many of them will have been spun out by people, by doctors, by nurses, by other practitioners that have worked in the NHS. So they're, in that sense, part of the NHS family. They've had to step out of the NHS to grow, and sometimes they've had to leave the country to grow. But built on the backs of NHS experience. So we're cutting off our noses to spite our face right now in that sense. So the NHS has got a huge role to play for these SMEs.
We'll come back to the life sciences, but actually you've had some direct experience in delivery for the NHS or certainly government in the NHS with the infected blood.
Yeah, the Infected Blood Compensation Authority. But I'll go back to a point that Zubir raised earlier around critical infrastructure and cyber and data, because you've got the 4 nation systems, for example, that hold a lot of this NHS and healthcare data for people living across the UK. Just making sure that's safe, secure, that's a big part. And again, that comes into the IPCA program that we're working on, where we've looked at the data platforms, a lot of the infrastructure related work to secure the compensation payments that are going out. And of course, that's in partnership with one of the SIs that we're working with. But not only that, I've started to see pockets of entrepreneurial individuals partnering with doctors, creating solutions, and some of them, for example, 6 GPs, being able to call up your GP, you have to do it morning, 8 a.m., wait on the phone, maybe ring a few times because line's busy. Yeah. So there's small bits of innovation that's going on just to solve that one problem, for example's sake. But what I'd like to sort of hear from you is around how do we get these small pilots, and then talking around healthcare being one of the biggest spends for government daily, how do you work on scaling that? Because everything that we've discussed does hone down into that, because you've got a problem, solution, foundation built, and then scale comes after it. But where do you see that happening?
I think that's where the NHS needs to think about. It's got a clinical entrepreneurship program, which has run for over 12 years, which is run by a brilliant urologist called Tony, whose surname currently eludes me. He'll kill me when he finds it. I don't remember his surname. From Essex.
Use AI to put it in afterwards.
That's right. From Essex. Wonderful man who I met when I was a minister. But what he's doing is encouraging the kind of nuts and bolts of entrepreneurship. What he's been unable to do is bring any funds along with it. But Guy's and St Thomas's, under again the direction of a really inspiring plastic surgeon called Nadine Haram, managed to build a fund. And she grew that fund by investing in companies just like the ones you're talking about, who've got an idea, who need a bit of money to develop it, scale it a bit, and then exit. And so I think the NHS has got a massive role to play in that, actually. But for the NHS to do that properly, whether it's at the kind of lower level of this individual ideas and seeding entrepreneurship of a consortium of individual clinicians, or whether it's taking its rightful place in the life sciences sector economy, I think it's got to really redefine its purpose in the 21st century. And I think almost at a constitutional level, I think it needs to needs to embrace entrepreneurship and the commercial sector, and understand that actually, if it's going to stay true to its values and its foundational purpose, the only way to do that is actually to get on board with funding its entrepreneurs and also becoming a full and willing partner in the life sciences sector.
What you talked a little bit about, well, we were chatting before we started recording about the buying of drugs.
Yeah.
And the pharma deal that we have with the States.
Yeah.
And also the fact that it fits in with the NHS being a single buyer, single buyer. How do we get to maximise our opportunities for getting a decent deal for our patients?
Yeah. I mean, listen, I think, those listeners that are insightful about these things will know the controversy, in inverted commas, the deal has caused. It's actually not controversial whatsoever. We have managed to secure some of the lowest prices in drug procurement of any country in the world. That's both on the novel medicine side and the generic medicine side. And actually at the time, that sounds like that's a great thing to do, but it's caused us a lot of problems in securing a supply chain at times for medicines where there are sometimes shortages on the generic side. And on the novel medicine side, it's actually blocked our citizens, our patients, getting access to novel life-saving drugs, whether it be for breast cancer, endometrial cancer, young kids with muscular dystrophy having to, deteriorating from that condition. So fundamentally, I think this is a moral issue. Like if we hadn't redefined our relationship, we were harming our own citizens. But moreover than that, like there is no pathway to a left shift in the NHS from sickness to prevention that doesn't involve more medicine spend, because some of these medicines that are now coming out, like the ones I described and others, are life-changing, life-saving, and they are ultimately going to have a monetary benefit in the terms of reducing NHS usage. And at the same time, some of this medicine spend is just about doing things equitably across the country. If I can give you an example of a drug called SGLT2 inhibitors that are about reducing deterioration of kidney disease to the point where you might need a transplant, which is what I do. I do kidney transplants as part of my job. If you look at the distribution of how those medicines are used up and down the country, I mean, there's some places where nearly everyone that needs them gets them, and other places in the country, not even 20% of people are getting them that need them. And that what you're saying there is basically these patients are on a pathway to declining kidney function and probably on a pathway to getting a transplant or dialysis for the sake of a pill a day. And some of that medicine spend is actually making sure that people are equitably being serviced up and down the country. So Andy talks about growth in every postcode. Well, you're not going to get health in every postcode if we don't spend more money on medicines.
And a final question in this bit, I suppose, is because you talked a little bit about life sciences and biotech. Because when I was minister for the Royal Marsden, where you were, next door was the Institute for Cancer Research.
Yeah,
so I think
great
pound
place.
for pound is the most profitable drug discovery company in the world.
Yeah.
But I remember talking to Paul Workman there, the boss there, how he himself had to develop drugs elsewhere.
That's
I think
right.
In Slough, they had to go to Boston and all sorts of places. They couldn't do it on site, which is why they're building there now. Now, obviously, we can talk here for a long time about the health benefits for that, but that's got a massive impact if we get it right on the growth of UK PLC. And we've talked a little more over the last couple of years about the growth of the UK economy and the need for growth.
Yeah. Listen, I think life sciences in the UK offers us an absolutely unique and unbridled opportunity to grow our economy. Other than the financial sector, I don't know of any part of our industrial strategy or economy which is so ripe and ready for us to put the foot down on the accelerator. Like at the moment, the life sciences, I think, adds about 16.5 billion of gross value add. It's maybe a 30 billion industry. I don't see why, if we don't make the right decisions politically, both on capital flow and on the NHS playing its full part in life sciences, why we can't grow that to a £100 billion industry by 2035. Genuinely.
How do we make that happen?
So I think on the NHS side, it's about talking about some of the things I was saying about before, really them internalizing it as an objective. Like I well understand, having worked in the NHS, the bandwidth the NHS has in terms of, firefighting the day-to-day issues, whether it be GP access, whether it be elective waiting lists, whether it be, corridor care, whether it be A&E waits, whether it be ambulance waiting times. But I think seeing the wood for the trees is really important for the NHS. And like every single institution in the NHS that embeds research into its ecosystem properly sees these metrics improve. Research is not only monetarily beneficial to the organisation, it is clinically and materially beneficial to the patients that come into that organisation. And it's about getting that strategic mindset shift in those NHS leaders. And that also has to come with political direction. For instance, for the first time when I was a minister, we were able to put in the planning framework that is the kind of marching orders that we give to the NHS every single year, that getting clinical trial setup times below 150 days was one of their core objectives as an organisation. And we did it. So I think the NHS needs a little bit of a constitutional reset, but at the same time, the money needs to flow. The Mansion House speeches done by the Chancellor need to be properly operationalised. Like, we need to get £500 million plus out of pension funds into life sciences companies so we can scale businesses that are built in Britain to stay in Britain and serve not only Brits, but the world.
Fantastic. Well, thank you for that one. I cannot let you go without a quick fire round.
Yeah, that's all right.
Question. So Asad's got that.
So I was going to say, from Glasgow to medicine to surgery into Parliament.
Yeah.
I've got some questions here for you.
Yeah.
So what would be the best piece of advice you've received within your medicine career or within politics?
The best piece of advice I've received in medicine and in politics, in fact, from different people, and that's why I think it is the best piece of advice, is always protect your reputation. Your reputation is your biggest currency. My dad always taught me that, my surgical mentors always taught me that, and my political mentors always taught me that. Your reputation is your currency.
That's a great one.
And never ever do anything that ruins your reputation. And the best way to do that is to stay true to yourself. I know it's a cliche, but...
So what's more stressful?
Yeah.
Operation theatre or the chamber in Parliament? Well,
certainly politics is more stressful than surgery. I would say so. Perhaps that's because I've been doing surgery for 20 years and it is second nature to me, and I'm probably still learning my craft as a politician. Maybe it's that, but I genuinely think, like, when you're in the operating theatre, most of it is kind of under your control, even when it's going badly. And, I've been in many situations where it's gone badly. You feel like you're still in control, and you can almost slow it down in your head when the crisis moments arise, and it's kind of a funny situation in the operating theatre. But with politics, like, there's always, as you know, so many moving parts out with your control. And events, dear boy, events, as they say, right? So in that sense, it's more stressful. I think sometimes it's difficult for someone like me that's so focused on an end goal with surgery to work out what is the definition of success at the end of a day or a week or a year, or perhaps a career in politics. That also weighs on your mind. I think for someone like me that's always been goals driven. So I would say definitely politics, and definitely the House of Commons chamber is more stressful than surgery or the operating theatre.
I think the training's better in surgery, right?
You would hope so, yeah. You would hope so. But listen, both of them, the best training you get is on the job. There's nothing like just getting in there and doing it over and over and over again, whether it's operating on someone, whether it's getting in front of someone at the dispatch box, getting in front of an interviewer and putting yourself in stressful situations. That's how you get better.
Very true.
And what would you say is the biggest opportunity for AI in healthcare?
I think the biggest opportunity for AI in healthcare is diagnostics, because a lot of the bottlenecks and where care kind of slows down or doesn't happen well happens because people are looking after you are worried about uncertainty. And if AI can come in and take away certain levels of uncertainty, allow people to make decisions where they become paralyzed by decision making because of the risk they're carrying by that uncertainty, I think you can make phenomenal changes in clinical pathways, outcomes of patients, early diagnosis of problems, and actually having a happier staff.
So with every opportunity comes risks as well.
Yeah.
So what would you see as the biggest risk for AI in healthcare?
The biggest risk for AI in healthcare is, it goes back to that original point about continuous learning, right? I think the biggest risk of AI in healthcare, and this perhaps applies to other settings, is like it's absorbing the information of today, and is it allowing the opportunity and the presence of mind for today's clinicians to still have the same ability to go out and seek knowledge, apply knowledge, push the boundaries of new knowledge? Because that's still a human endeavor. AI can't really do that. I think some people think it can. I'm not sure it can. And so the biggest risk of AI is become really efficient and productive for a generation, but actually what happens after that generation.
So what would be one piece of NHS framework you would abolish tomorrow?
I would actually if I was being very bold, I would tear up the consultant contract, the NHS consultant contract, and say, look, guys, this is the contract that's been in place for 27 years. You guys are the leaders in the NHS. You guys are the public they look to you as being the creme de la creme of medicine. It's not working for you, this model. Let's think about a new model where you're able to take more leadership, but also more accountability for what you do. And let's think about how we remunerate that beyond just a simple salaried worker model.
So forget the negotiations, just start again.
Do you know, I think, you know,
after
I think there is room for some serious disruption, and I think there's appetite for it from a certain number of consultants, certainly colleagues that I've worked with, and I think there's appetite. I think that's what's needed. I think you can, you know, with AI coming in, transforming pathways, changing care, patients' expectations. I think there's actually a dearth of managerial excellence in the NHS as well. Like there's almost like a perfect storm coming, but also a perfect opportunity that I think consultants and clinicians can step into.
So what's one technology every minister should get their grips on or understand?
I think every minister, certainly in a delivery role, needs to get to grips and probably define what are the top 5 companies out there that can help them rewire their institution. Because like I say, hundreds come at you and you never properly have the time to evaluate them. So every minute, it's not so much about the technology, it's about AI, it's about technological solutions, but you got to pick your partners. Pick them early, and ideally, if they're British, invest in them at the same time. So you're co-creating that future.
So I'd like to understand Dr. Zubir Ahmed, Member of Parliament, a bit deeper. Who's one person or mentor who helped shape you?
I don't think there was one person, but I've been shaped by a number of, I would say, surgical mentors over the years. Many of them have been first-generation immigrants to this country, from the Middle East, from Pakistan, from India, that have done it the hard way. And I think just listening to them, watching their journeys, watching how they stayed resilient has really inspired me about, like, you know, at times, but never giving up. Or I think there'll be a few, to be honest. And I'm not going to embarrass them by naming them, but I can actually think of them as I'm sitting here.
Oh, fantastic. Final question there. And you said, actually, I think you started talking about this when you're saying being goal-oriented.
Yeah.
But if you back here in, say, 8 years' time, we were chatting again, what do you think success looks like in from what we've been talking about in technology in the NHS, rather than, you know, waiting lists or the political debates that we always have?
Do you know what I think success
as
is?
important as they are?
Success of technology in the NHS in 8 years looks like us not talking about technology in the NHS.
Yeah.
That it's just in the background. Like, I know it's exciting to talk about it now. A lot of my colleagues talk about it. Every other medical paper you read now is about AI analysis of this, machine learning of that. At management level, it's about how we can get rid of a doctor here or a nurse there. But, you know, fundamentally, the NHS is a human endeavour. It's always going to stay a human endeavour. Even the most ambitious simulations of any workforce plan that I've ever seen has never seen NHS staff dwindling in large numbers. So it remains a human endeavour. So I think the success of technology is actually, we don't talk about technology in 8 years' time, but everyone still has confidence in the NHS because the technology is there, but we don't need to talk about it anymore because it's just kind of innate to the day-to-day workings.
Well, Dr. Zubir Ahmed, thank you so much for your time. Really appreciate it.
My pleasure.
That.
It's been fun.
Asad, I mean, that was fascinating as we thought it was going to be, isn't it? Interesting. We've had someone who speaks refreshingly, as someone that knows his brief really well, not only through his ministerial period, but obviously what he brings to the table. It doesn't often happen in government that they actually promote people into these places that have had a background in that, that particular area. But we spoke a lot about, we can take a lot out of that, about the pharma deal, about confidence in technology that we need to build, about the potential for 100 billion life sciences sector as well for UK growth.
I think certainly the point that was raised around we've got a lot of this capital locked in pension funds. It needs to come out, and it needs to fuel that innovation and growth, because we're going to be losing out otherwise in the UK if we're not really stepping into that space now.
Absolutely. Well, look, thank you very much for tuning in as ever to the Digital Estate Podcast. You can get the podcast wherever you usually get your podcast from. You'll be able to see us in full colour on YouTube. And I hope you'll comment. I hope you'll suggest guests. I hope you'll suggest topics. But do keep tuning in, because we've got a lot of other guests coming forward. And we're going to have a great conversation about various sectors of technology and how it impinges on government, and therefore how it impinges on all of us. Till the next time, goodbye.